Okay, so joints, the same, a joint is an articulation. I mentioned for the hyaline cartilage, um, wherever two bones articulate, wherever two bones meet, that is a joint, and it's going to glide across one another by hyaline cartilage. It's articular cartilage. Articular cartilage is the name, and it's made of hyaline cartilage. So, you know, a joint bends and wiggles. Some of us bend and wiggle better than other people. Maybe that's because you have really loosey-goosey ligaments. Maybe it's because you're extremely athletic. So you've really done a great job of tuning up your muscles and making them nice and flexible. But whatever, we all bend somewhat. You would have to say practice being really good at a back bend, would you not? And maybe at one point in our lives we were all decent at it, but if you didn't keep practicing it, a back bend is a major feat for some of us. So, like so many things in A&P, you can classify things by structure, you can classify things by function. So structure is what it's made of. Function is how does it work. So the structure of, let's say, your suture line is fibrous. So we've got fibrous connective tissue holding the two pieces of bone together, say the parietal bone to the frontal bone. But it doesn't move. So that suture is a synarthrosis. And I alluded to this the first day of lecture for bones. A cartilaginous joint has cartilage between the two bones, and they are usually referring to fibrocartilage, and it moves somewhat. So therefore, it is an amphiarthrotic joint. So cartilaginous joints are amphiarthrosis. And examples would be your back, so doing that back bend, or your pubic symphysis. These are semi-movable joints, slightly movable joints. Most of our joints are freely movable though. So by function, they're a diarthrotic joint. By structure, they're a synovial joint. And what that means is it's got a slimy fluid in the inside of it called a synovial fluid. And it's freely movable, so you can wiggle it in lots of different directions. And even those are going to have different classifications. So some synovial joints are so ridiculously movable that they actually can come out of socket, like your shoulder. So a little bit more detail on the synarthrotic joints. There's no cavity, there's no big space. They are just linked together by connective tissue. So I gave you the example of sutures, but a couple of others, syndesmoses and agamphoses. Here's a suture. They're just all locked together, so they're not locked together when that skull's still growing, right? We need the brain to have room to grow, so they're not linked and they shift a lot, and that allows for the bone to grow and the brain to grow. But it's going to end up fusing together because we're done growing, and we need to be sure and have good protection on that brain. A syndesmosis is going to be like bands of tissue, usually connecting two bones next to one another. So your tibia and your fibula, or your radius and your ulnar, are excellent examples of where you can find this synarthrotic joint. This syndesmosis is the branch of synarthrotic joint. An agamphos joint is going to be that periodontal ligament that's holding the tooth in the alveolar process of the mandible or the maxilla. So holding the tooth in place. Okay, again, cartilaginous joint. So it's made of fibrocartilage. It's slightly movable, so it's an amphiarthrotic joint. And this is going to be the two examples are going to be the intervertebral area and the pubic symphysis. But synovial is full of a slimy fluid called synovial fluid. It actually has a membrane around it. It's a synovial membrane that's making that synovial fluid. And it's slimy. It's making it nice and lubed up so that we can wiggle around. Now, some are going to have more movement than others, like I mentioned. And we're going to break it down into different types, and you'll see that those different types have different directions that they can move and different stabilities. Some of them will have a bursa or a tendon sheath associated with them as well. So again, articular cartilage is hyaline cartilage, so it's made of hyaline cartilage, but if it's at a joint, it's got a name. It's articular cartilage. So articular cartilage is the name, but it's made of hyaline cartilage, and it adds a little bit of cush. The synovial cavity, or joint cavity, is a space. It's not massive by any means, but it's where we've got some fluid so that the joint can glide around better. And then we're going to have this capsule, which is going to be a synovial membrane. And that synovial membrane is what's making the fluid. That's on the inside. And then there is a very tough layer on the outside. So it's a double layered membrane, but those two layers are stuck quite together. And if you ever did surgery on a joint, you could definitely hear that scraping as you cut into the fibrous layer. It's very thick and tough. So again, that synovial fluid's pretty slimy. Hyaluronic acid is actually it's in there, and it's a supplement that some people will take to try and make their synovial fluid a little bit more slimy. It also has some protective macrophages in there, so phagocytic cell is a macrophage, to be on the lookout for any debris that might sneak in there. It is bad if a joint gets invaded. So there's always some macrophages in there that are trying to protect that joint. But again, it is bad news if somebody actually figured out a way into that joint. And if you've ever stretched one of your joints excessively, or of course torn anything like your meniscus or your anterior cruciate ligament, you have felt there's a lot of nerves in there. So there's a lot of nerve receptors, and there's blood vessels in there. Capillary beds are more in the actual synovial sac around the joint than actually in the joint. So sometimes we have these areas, these pockets of synovial fluid that are not in the joint, but they're somewhere around the joint. And a bursa is going to reduce friction wherever we have ligaments, muscles, tendons, wherever there's potential for these things to rub together. And then a tendon sheath is the same thing as a bursa, but it's more long, and it actually ends up being this total wrap around a tendon to reduce friction. So a tendon sheath is more elongated and complete. In this picture right here, this little pointer on, this is a bursa, so a pretty small little sac, and it's protecting against the rubbing from the acromion of the scapula over this. There's got a small tendon right here, and then we have the humeral head right here. So we don't want things rubbing on that. We need it pretty cush. So we're going to have a bursa here. Now this wrap that's actually elongated and completely going around this tendon right here, well, that's going to be a tendon sheath. Same idea, just a lot longer. Whenever we do muscles, you're going to see this again. Muscles are going to originate somewhere on a bone, and then they're going to insert on a bone. So what does that mean? Wherever they originate is going to be closest to the core of the body, closest to the trunk. So, for example, if you have something that is originating at your clavicle, it's going to insert further away, say distally down your arm, perhaps on your radius, perhaps on your distal humerus. So an origin is going to be wherever we have a muscle attached to bone, closest to the trunk, closest to the core of your body. And it inserts usually away. Now I say usually because sometimes it's going to originate on the trunk and then insert somewhere on the trunk. So then the origin and insertion would be interchangeable, such as your abdominal muscles. Most of them, or like the rectus abdominis, the straight six-pack muscle. I've never had one of those. But anyway, its origin and insertion is both on the trunk. Okay. Whenever we have a muscle to contract, that means it's getting shorter. So what's going to happen is those origin and insertion get closer to each other, right? Because if it's originating point A, inserting on point B, and now we made the space between contract, get smaller, well then the insertion is going to move closer to the origin. And we have different kinds of movements. We have gliding movements, angular movements, rotation. This example right here, this gliding movement, sometimes you'll even see it called a gliding joint. And the excellent example of these two are the little, you have so many carpal bones, you don't have to know any of the names of them. They glide against each other. So they move short distances back and forth. Also in your ankle, so you have intertarsal joints that are sliding against one another. And that's going to be a gliding joint. Angular movements are when we're going to increase or decrease the distance between two bones. So flexion is when we're going to decrease the angle of a joint. Extension is when we're going to increase the angle. So in this one, we've got the neck. So she is bringing her chin closer to her chest, and that would be flexion. When she looks up, she's bringing her chin away from her chest, so that's extension. Then when she looks up, that's hyperextension. Let's do another example. Some people, they'll say that they're double jointed. It doesn't mean they've got two joints. It just means they got some loosey-goosey ligaments. So let's do the elbow joint. When we bring our hand closer to our shoulder, that is flexing it because the angle of our elbow is getting smaller. And then when we bring our hand away from our shoulder, then we're increasing the angle of our elbow joint, and that would be extension. If you are one of those quote-unquote double-jointed people, and we've probably all seen that person that can extend their arm so that their elbow is more than 180 degrees. They make it more like 190, 200 degrees. That would be hyperextension. And for those people that have those loosey-goosey ligaments, that's fine. But if it's like a football player or something that just gets his arm knocked and then you can see like his knee doing something like that or his elbow doing something like that, and then he starts to cry, well, then that probably joint that got hyperextended. So flexing your trunk would be bringing your, like bending down to touch your toes, standing back up. So straightening up would be extension, and then hyperextension would be going to do a back bend. On the bottom left, let's talk about this one. If somebody abducted your child, they took your child away. So on this, when she brings her arm away from her body, she's abducting it. She's taking it away from the core of her body. When she's bringing it back, that's adduction. So if you think about bringing something back to yourself, you're adding it to yourself, adduction. Rotation is when you turn on an axis. So she is just pivoting her neck from left to right there, or maybe you can take your palms and turn them backwards or forwards by their sides. That's rotation. Circumduction is how you can actually do like lassoing a rope or swinging your leg in a full circle. So circumduction is many different movements all at one time. Perhaps you are going to bring your leg maybe in front of your other leg, and then you swing it in front of you, and then you swing it out, and then you swing it around behind you, and then you swing it behind your other leg, and then you bring it back to place. So it's kind of conical in motion, like a cone. Those were all pictures that we already looked at. Okay, these supination and pronation is moving the radius and ulna specifically. So if you take your palms and you turn them so that they face forward and even maybe forward and up, that's supination, like you're scooping soup. Pronation is when you take your palms and you turn them over, like to lay your palms of your hand down on the flat surface of a table. That is pronation. Dorsiflexion is when you point your toe upward, and then plantar flexion is when you point your toes downward like a ballerina. So dorsiflexion is bringing your toe up. Plantar flexion is pointing your toe down. So let's talk about those 6 different synovial joints. We did these in lab. So the plane joint is the same thing as a gliding joint. So that would be your tarsal joint and your carpal joint. We already went through that one. But some others are a hinge, a pivot joint, a condylar joint, a saddle joint, and a ball and socket joint. This picture is showing how these guys glide across each other. A hinge joint is going to be at, say, your elbows, or maybe can you bend your fingers downward? Can you bend your toes? How about your knee? They bend in one direction. A hinge joint bends in one direction. A pivot joint turns on itself. So in that other picture, we saw her pivoting her neck, right? So she was rotating her neck from left to right. That's a pivot joint. There's going to be some sort of little ring of tissue that's holding another bone in place, and it just turns on itself. So your elbow actually doesn't just have a hinge joint where you can bring your hand up to your shoulder, but you can also do pronation and supination, right? Turning your palm up and down by turning your radius and ulna at the more proximal end at its pivot joint. A condyloid joint is going to be kind of like a golf tee. You can take this guy and flex and extend him, and you also can bend him a little bit from the left to the right. So this is using an example of your knuckles. Your thumb is a great example of a saddle joint. This is what makes our thumbs opposable, which means that we can use them to pick things up. This is going to be where your carpal bones meet your first, your carpal bones meet your first metacarpal bone in your thumb specifically. So it's called a saddle joint because of the way that it actually looks. It looks like a saddle sitting on top of a saddle. Ball and socket joints are the most movable joints. So this would be the shoulder and the hip. So the glenoid cavity of the scapula is actually quite shallow. So it's not really that deep of a socket, as opposed to the hip, where the femoral head sits inside the pelvis. That is a very deep socket. So the shoulder pictured here, you can see how it's very, very loose. And we're going to have some different ligaments that are trying to stabilize this, but this is definitely the most easily damaged joint that we have is the shoulder joint. Your knee is quite complex, and this is the only place where you're going to have to learn any of the ligaments. You don't really think about this, but there's actually different joints. So we have where your tibia meets your femur. That is one set of joints, a medial and a lateral side. And then we actually also have a joint between your kneecap and your femur. So that's the femoropatellar joint. This picture is showing somebody has come and hit this person in the knee. And remember that ligaments and tendons are made of dense, regular connective tissue, strong tensile strength in one direction. So those collagen fibers are nice and packed together, little lasagna noodles going from top to bottom. But if you hit that guy from the side, it's not strong that way. It's strong keeping your femur attached to your tibia. But if somebody comes and hits it from the side, it tears. So the ligaments that you need to know in the knee, the anterior cruciate ligament is depicted here, torn. There's also a posterior cruciate ligament behind this that is not drawn. And the reason they get the name cruciate is because they look like an X across. And it's rare for the posterior cruciate ligament to get torn. It would have to be some pretty significant trauma. And then on either side, you have a medial and lateral collateral ligament. And on the inside, you have these cushions, these meniscus that are made of fibrocartilage. Fantastic little cushions. And they get torn sometimes too. On the lab test, he could put an arrow on either of these collateral ligaments and say, what is it? And you would have to say medial collateral ligament or lateral collateral ligament. So what would make it lateral? Well, if it's on the side with the fibula, that is the lateral collateral ligament. So this one right here is the lateral collateral ligament because it's on the same side as the fibula. And this is the medial collateral ligament because it's on the opposite side from the fibula. Arthritis. What is arthritis? Well, this one you get these little bone spurs in your joint. And it's usually just from wear and tear. You use your body so much and we have a tendency over time, just things wear out. Things just don't work like they used to. And it hurts. If it's arthritis just from wear and tear, then there's different things that we can try. Stem cell therapy may or may not be helpful. physical therapy to make sure that your muscles are as in good a shape as possible. So you're not asking so much of the joint as you are of your muscles to do the work. And there's supplements that we can try to help slime up that synovial fluid. Sometimes when we have arthritis, the inflammation from arthritis makes that joint fluid watery. So we can slime it up with some supplements. This picture right here is showing a normal hip joint on the left. So here we have the ball and socket joint. So the ball is the head of the femur. The socket is called the acetabulum. It's much deeper than the glenoid cavity of the shoulder. Anyway, on this one, this is showing how not just do we have well, they didn't even draw bone spurs. They should have drawn some bone spurs. They're showing a decrease in joint space, and which is from the inflammation, and we're having wear and tear the cartilage, the hyaline cartilage. So this articular cartilage is being eroded away. And so when somebody says they have bone-on-bone arthritis, they don't have any hyaline cartilage left. And so all that's left is bone touching the bone, which creates more inflammation, which creates more pain and more rubbing and more inflammation and more, you get the idea. Now, rheumatoid arthritis is a different form of arthritis. This is not wear and tear, but rather the body gets confused and starts attacking its own joints. Not really sure what causes that. There may be a genetic link to that. Gouty arthritis, this is when for some reason we start depositing uric acid crystals in our joints and soft tissues. The big toe is actually a pretty common place for gout to set up house, and it really does hurt. If you don't treat arthritis, especially like gouty arthritis, but if you don't tend to it, what can end up happening is those bones fuse together. But if it's not a perfect fusion, if it's not completely immobilized, if with any wiggling, you're still going to have bone grinding on bone. So sometimes with certain things, especially like bad ankle injuries, a doctor will go in and intentionally fuse bones because that's the only way to stabilize that joint. And once you're fully stable, some of the pain goes away.